do some clinical evaluations or interpretations for people who may have had exposures and being monitored for asbestosis, that sort of thing. But typically what we're doing here is occupational health stuff. If you have any clinical questions, I will try to answer those. But if I can't do it, I will refer to my mentor here. Melissa actually is the one who taught me how to do this stuff and do it in a way that gets good results. So if I say something wrong, you can just kind of correct me off the side there, okay? All right. So reasons to perform spirometry. I'm just going to say PFT because it's easier. PFT is pulmonary function testing, and I think most people use that term, but this is the official term here. We want to detect occupational lung diseases, COPD in smokers. That's typically what you're seeing from the COPD. It's mostly associated with smokers. So. And then asthma and severity. And it's also used in a clinical sense to check to see if medications are doing what they should be doing or expected to be doing. All right, COPD statistics. This is mainly for emphysema and chronic bronchitis. You can see with the numbers here that it's a lot. 122,000 deaths per year. That is a lot, and it's the fastest growing cause of death and disability. And it's also rising faster in women than in men. This was I tried to find out the exact date that the study was done with these numbers. I wasn't able to get the exact date, but I do remember that one of the reasons why it was rising faster in women than in men is because of smoking. Women were increasing the consumption of smoking more so than men. I don't know if that's still true today because these numbers here are actually a few years old. All right. So COPD, what is it? You guys know what it is? Ben, you know what it is.
Pulmonary disease.
Okay. So typically in the bronchial, this shows a nice open one. Right there. I try to get a really good clear picture, but it's not showing up too well. Can you see how it's a nice big hole here? And this one here, it's actually showing that it's not. It's neck down. It shows a thick wall because of the incubation. Okay, that's what it is. It basically what it's obstruction. You're obstructing the ability for air to flow in and out of the lungs. And that's what's going on there. Okay, the cost of COPD, $106 billion. That's a lot. So you can see why people are really interested in keeping the cost down and controlling it. And what we have coming into our clinic are people that are going out into the workforce or going into a special project, and they may have some type of exposure, either fumes, toxic chemicals, asbestos, that sort of thing. And they want to keep them protected so that we can help get this cost down. Okay, the thing about PFTs is it's the only test that you can perform that will actually give you some information to determine if there's a problem or not. An X-ray, or if you're using a stethoscope to listen to lungs, that won't give you an early detection, but a PFT will. Okay, so that's why it's so important. Especially in workers. If there's anything going on with their lungs, we have to know about it before it becomes a real problem. Okay, so that we have companies that we do annual PFTs with. We do pre-employment PFTs, and we do PFTs on anybody who they suspect may have a problem or has been possibly exposed, and they want to get another baseline to see if there's a change. Now, a PFT is used to make an interpretation, not a diagnosis. Okay? It's just one of many tools used to help make a diagnosis, but it's not the only thing that's used. So don't think that you can say, oh yeah, that guy's got asbestosis. His PFT was low. No, that's not the case. You don't know what's going on until you do other tests as well. All right, so prevalence of COPD. Workplace exposures account for 19.2%. So that's quite a bit. So you know why, part of the reason why I'm in business with occupational health, because we got that kind of numbers coming to us. Chronic bronchitis, 40.2 people per thousand. So 9 million affected in the U.S. Asthma, 38.6 per thousand. That's almost up there with bronchitis. Emphysema, which is a little more smoking related, but that's still quite high. Oh, by the way, if you have questions, feel free to ask Melissa at the end of the presentation. No, go ahead and ask any questions if there's anything you want a little more elaboration on. So do you guys remember your medical terminology? Okay, Spiro, breath, metric, measurement. Okay, this is actually an old procedure that was developed in 1846. Dr. John Hutchison was in England, and he's the one who developed it. And basically, his first machine was probably, I've seen a picture of it, it's like huge. It looked like a time machine from the old days or something. And it used bellows action, and they actually measured everything. And everything was done manually. He figured it out, and all the math was done manually. So that was a lot of work to actually get results back then. And what it's doing is it's measuring the amount of air that can be held in the lungs, volume in liters. Everything is in liters. We don't use American units. And it measures how fast that the lungs can expel that amount. And we're using a spirometer, which is this. Okay, so if you have any math background, basically what's being done is these are the criteria that's being used to find out what's going on with your lungs. Volume is basically the capacity that the lung can hold. Okay? And time has to do with how well you can expel that air in seconds. And then flow is the amount of air you can expel in a specific amount of time. Okay. So,
on the volume, does that depend upon the person's height, weight, stature? Or is it?
It does play into it. When we do one, you'll see that I'm going to input gender. I'm going to put in ethnicity. I'm going to put in height and weight.
Did you bring the screening questionnaire?
Yes. Yeah. Good question. Which will lead me into that a little bit later. So, yeah. Now, the physiology of the person is looked at because there's a expectation that a person this age, at this height, and this weight, and this ethnicity, and so on, should have an expected value of a certain amount. Okay, and that's based upon studies and is actually programmed into the machine. Okay. I don't know exactly how those numbers play in the calculations, though. I've never seen the actual formula, and even if I did see it, I probably wouldn't understand it. So. But anyway, these are the three main things that is used in formulating the results. All right, so FVC, forced vital capacity. This is the maximum amount of air forcibly exhaled from the point of maximal inspiration, okay? So, you're taking a breath and you're expelling it out, and that is what your FVC is, the total from, typically when we breathe, they call it tidal breathing, okay? We don't go all the way in and all the way out. We just go. They call that tidal breathing. And FVC is all the way in and all the way out. Okay. And basically, this measure is used to determine restrictive lung disease. Okay. Restriction meaning today I have this much capacity in my lungs, but because I've led an unhealthy lifestyle, a year from now, my capacity is now this much instead of this much. Okay. Smoking, that's what we're doing. All right. FEV1 is the volume of air forcefully exhaled in 1 second. Okay. This particular measure is used to determine if we have an obstruction. Okay. For instance, you have inflammation in your system, in your lungs. Okay. That's an obstruction. Okay. Or maybe you got something else going on. You got mucus. Maybe you got some nodules that are kind of growing in there. Something. In other words, this measure lets us know if the air can't get out because it's having to force its way out. It's like taking a garden hose and cinching it down. Okay? That's what it's like. Okay. Now, this calculation, the FEV1 and the FVC, is basically used to detect small airway obstruction. Okay, so we're not talking about the trachea, we're not talking about the bronchi, we're talking about down lower. Okay, and this was used more in a clinical setting, not so much in an occupational health setting. We're typically looking at FEV1s on its own and FVCs on its own, but not this so much. On occasion we will. We do have a few patients that come in and they have been exposed to something in the past, and now we're monitoring them to see how the lungs are doing over a period of time. And some of the patients we have been coming in for 10 or more years. Okay. Sometime in the past they've had an unusual exposure.
Do you do long-term studies?
We're not doing studies ourselves, but we are recording the results on patients. And if we see a significant change, then we have to report it. Okay. All right. So the three types of lung disease include obstructive, restrictive, and mixed impairment. A mixed impairment is a combination of obstructive and restrictive together. Okay. So to kind of recap, the obstruction is basically like a garden hose that you're cinching down, making it smaller at one point, and the water can't get through as fast. A restriction is you're using a smaller garden hose. Okay, just have it small, it can't let the water come through instead of having a big one. And then a mixed impairment could be both. All right. So obstruction, a disease process that slows airflow out of the lung, and restrictive. Any questions so far? So bronchitis. Okay, this is a better picture. So here's a normal bronchial tube. See how that looks? In bronchitis, you have inflammation, which restricts. It's taking it down. Okay. So the air can't get through as fast. And there's usually mucus involved with that as well. So what causes bronchitis? Smoking, secondhand smoke. If you have a history of respiratory infections, hereditary. Industrial exposures, sulfur dioxide, for instance. That is a toxic gas, and if you are exposed to it, not only can it mess up your lung, it can kill you. What it does, those things will cause inflammation and mucus that's protecting. When it inflames, the mucus is a protector. And it results in reduced airflow, coughing, that sort of thing, shortness of breath. Emphysema, okay, this is usually smoking related. And in here you can see what a healthy lung looks like, and then the alveoli, that's what a healthy alveoli looks like. When you start smoking, you start getting deposits. It's kind of hard to see here, but in here, in these sacs, you can see little deposits from the cigarettes. And then it continues to get worse and worse. And then what happens as a response to those deposits, the alveoli actually starts getting eaten away, and all of a sudden now, instead of these little tiny sacs you have here, you got one big sac that's useless. Okay? That's why emphysema smokers, they have reduced lung capacity because of that. And if you've ever been around anyone with emphysema, they're always short of breath, they never catch up on things. They're like this. Just like that. Okay? It's caused by smoking, chemical exposures, you have loss of airway support, alveolar obstruction, so on and so on. Asthma, anyone here have asthma? Tell us about asthma.
I hate it.
Yeah, nobody likes it. So basically, this shows a picture, and it's like bronchitis in a way. You have a normal airway, and then this one here, you see the inflammation with the mucus in there, and it strips. And people with asthma, trying to catch their breath, get tired easily if you know, keep it under control. And it's obviously an obstruction type disease. And not everyone with asthma is affected in the same way. Some may be pollen, others may be cold air. It's just, there's no predicting how people will be affected by it. And I guess it's affected by exercise too. I didn't realize that. I guess if you're using the lungs, if you're stressing the lungs, and their response is to become inflamed as a result of that.
I found with my exercise, I do a lot of water aerobics, and if they have treated the pool just recently with
Chlorine?
chemicals, chlorine or bromine or whatever, I can tell the minute I'm walking.
Oh yeah.
So it's definitely tick, 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 tick.
It's an obstruction type disease, and it says airway hyperactivity. So it can, because it's a hyperactivity, it can come on quick. I worked with a guy at a manufacturing plant, and we had dust and chemical fumes and stuff throughout the entire plant. He had asthma, and he just, I kept saying, why do you do this? I mean, you should look for a different career, but he just never took it serious. And people with asthma, I mean, they can be serious. They can be life-threatening if it's in the right situations.
I beg to differ, in the wrong.
Yeah, in the wrong. Okay, and so parenchymal disease is just a fancy name for general lung disorders, and but they usually use it in terms of asbestosis. Now, everyone knows what asbestosis is, right? And silicosis. All right. The thing about those two particular things is when it gets in the lungs, that stuff doesn't break down. It's not something that's natural that the lung can take. And not only that, it's like glass. It's sharp. And when it gets in the lungs, what it does is it's cutting. It's scarring the lung tissue is what it's doing. And that scarring is what causes the problem. And it can lead to cancer as well because of the continual scarring. And once it's in there, they can't get it out. So that's why it's so critical that if you're ever around any stuff that has that sort of thing, asbestos and silicon fibers, dust, that sort of thing, wear that proper mask. Some people that are in a work environment, they don't like wearing the mask because it's hot, it's sweaty, it's uncomfortable, that sort of thing, but they don't realize the flip side of that by not wearing the mask. So, if you know anyone that's doing that kind of work, make sure you let them know. Obesity, that can be a problem for restriction because people who are heavyweight, because of the extra weight that they're carrying, it puts additional stress on the lungs and stuff and causes a problem. And I didn't know this until I started studying for this presentation, that obese people, when they are breathing, they can actually breathe easier standing up than you can sitting in a chair. I would have thought it would be the other way around, but it's because of the geometry of how they're sitting like this. It puts undue stress on the lungs. And that's why sometimes you might see large people, if they're having a hard time breathing, they may get up like this so they can catch the breath. So, excessive particle load. Okay. How many here remember when Mount St. Helens blew off? Okay. I was around for that. You remember the dust? And what did everybody do? They ran to the hardware stores and got those masks, which was a good thing because some of those dust clouds, I remember having to drive through one, and I couldn't see 10 feet in front of me. It was that thick. Just really bad. But that's what you need to do if you're in an environment where there's a lot of dust. If you're sawing wood with an electric saw, and it's producing dust, which it usually does, you ought to be wearing that mask.
We live near a volcano that shoots out.
Pardon?
We live near a volcano that's...
Yeah. Keep the box of masks handy, huh? Okay. So effective restriction is basically reducing the volume that the lung can hold. And if you reduce the volume that your lungs can hold, but your body is the same size, it still needs the oxygen. And so with the reduced lung capacity, you're just not able to produce that oxygen for your limbs and the rest of the body, and so you're constantly short of breath. Like that, there. And also, it shows up, your chest shows up on an x-ray with little white spots. Okay, those white spots are bad on the chest x-ray. It means there's something there that shouldn't be. Okay, restrictive lung diseases. Okay, co-workers pneumoconiosis. Did I say that right? Good guess. A shorter term is pulmonary disease. Silicosis, asbestosis, pneumonitis, and again, obesity, as we discussed previously. Okay, and all right, here's a picture. So these are shards of asbestos. Can you see how it's sharp? That's exactly what it is. It's like glass, sharp glass. And it gets into the system and you can't get it out. And every time you breathe, your lungs are constantly moving. That movement makes those shards want to cut and cut and cut and cut, and it never stops. Okay? And every time you cut yourself, what do? You scar. Okay? And you cut again, there's another scar, another scar, another scar. And pretty soon you've got so much scar tissue there that that area of the lung is useless. You can't do anything. So even though most of what we're doing is for occupational health, in our clinic, we do have some patients that come in on the clinic side because they're on disability and they have been exposed to asbestos or something, and we're monitoring to see how their lungs are doing because they've had this exposure. Okay. This is nasty stuff. We don't want to deal with it. Okay, mixed impairment, basically that would be an obstruction and a restrictive type of disease process going on. And again, we're doing the FEV1, the FEC, and the FEV1 and /FEC. So we're doing obstruction, restriction, and a combination to see what's going on with the lungs. And then pneumonia would be a prime example of what's going on with that. Because you have inflammation and you also have mucus and all that going on. So I was trying to think of some other examples other than pneumonia. I couldn't come up with anything in mind. Is there anything?
Diseases?
Yeah.
Okay.
No.
Oh. I told you.